Before we get started tonight with Dr. Menchel, I wanted to just make a quick introduction here to Adam. Adam, is it pronounced Wachholz?
It is, very, very good.
Yeah, thank you. So Adam Wachholz is from RMO. He's from Rocky Mountain Orthodontics, a company some of us may have heard of. He has nothing to do with this particular event that's going on, but as more people trickle in tonight and as we talk about on the Facebook site, his company is going to be helping sponsor our January meeting. Hi, Darren. So Adam, who's here tonight, is going to be handling the sponsorship for our January meeting, which at this point is the cruise. He's been great with working with our group and really just asks for nothing more in return than we just spend some time paying attention to some of the vendors that he's going to put together for us. So I told him that I'd let him speak for just a couple of minutes here before the meeting so that he can bring anybody who wants to into the fold and understand more about what it is that's going on. So Adam, the floor is yours to talk a little bit.
I appreciate it. Thank you, Dr. Krieger. Thank you for having me. I really appreciate it. Look forward to meeting all of you in person instead of the virtual encounter that we're having today. But thank you again for having me on board for this. As Dr. Krieger mentioned, we're trying to put together a amazing experience for all of you guys. He has a lot of amazing ideas that we're looking into, and he's looked into, and we're trying to put together a cruise meeting. So I know some of you may have been on one of those before, some of you may have not, but those are usually a wonderful experience, a chance to kind of get away from everything and step away, but still learn and make it a great CE event. So we're still in kind of the planning phases of this, but if you have ideas or if you have anything that you'd like to share from a previous experience, please let Dr. Krieger or myself know. He has all of my contact information. I promise not to go on and on here, so I will keep it short and sweet, but just wanted to introduce myself. And if you have any questions, please let us know.
Yeah, and Adam, are you at liberty to talk at all right now a little bit about some of the sponsors, the 4 or 5 companies that might be there?
Yeah, so we currently have 4 committed. We have about 2 to 3 more that we're looking at. So obviously Rocky Mountain Orthodontics will be one of them. Bank of America is one that's committed in. Carr Healthcare Realty is one that's committed in. And then the one from the membership of you guys, Neon Canvas, as well, as committed in. Right
on cue, Kyle showed up.
What's up?
As you mentioned the words Neon Canvas, Kyle shows up. So Kyle, this is Adam Wachholz from Rocky Mountain.
Hello, Adam.
Kyle and I know each other well.
He's just been telling everybody a little bit about the sponsorship for the meeting. And so I told him he could talk for a minute or two. Some of you missed him. But Adam, we really appreciate Rocky Mountain, not just as a company, but you guys stepping to the front and just willing to help us out with our meeting and defraying some of the costs for the members, and at the same time asking really honestly for very little in return other than just talking about a few things here and there and introducing us to some new sponsors. So
absolutely. Tell Kyle to drive safe. It looks like he's in his car.
Yeah.
Yeah, Kyle, you're not doing this while you're driving, are you?
I am. I'm pulling through at Chick-fil-A, actually.
You've been hanging out with Dr. Shaw again?
Hold on. So, I'm not muted. Here, this is where I am. Chick-fil-A.
Dr. Menchel, welcome to the group, and thank you. Can you grab him a whatever? I'm kosher. I don't even know what they serve. Get him something good.
Kosher. I'll get you a super salad. It's kale.
I think it's part of it then.
Is it? So
yeah, go ahead.
Let me take a moment to introduce Dr. Harold Menchel. He's been a mentor of mine since I first met you. Where? I met you at the Ritz-Carlton, Cancun, right? Probably about 15 years ago.
Sounds about. I can't believe it's that long ago. Yeah.
He had a video. This crazy dude at a dental meeting had a video of some guy bruxing while he slept, and it sounded like a cement mixer. I'd never heard anybody grind like this, and everybody kept telling me, "You need to get to know this guy. He really knows what he's talking about." Well, during the past 15 years, I agree with what they've had to say. He's trained under a legend at Florida for oral-facial pain, TMD, anything you want to know related to the joint or occlusion, this guy knows. I pride myself in having spent 3 years at the University of Washington's pathology department back around the turn of the millennium. And I thought I knew about a lot about occlusion until I started running with Dr. Menchel. And he just knows so much, and so much so, we were so lucky to have him in South Florida that when I was at Nova, he was so generous with his time that he came and gave us a bunch of lectures on TMD and joint anatomy and how to diagnose. Dr. Menchel was remarkably helpful for all of us. So I really appreciate it. And he's giving up his time tonight for no other reason than just to help educate our group. So with that, other than being just an amazing human being and an amazing diagnostician, I just want to thank you for being here tonight. And I'll start the conversation wherever you want to pick it up, Dr. Menchel. So if you want to talk about the case first?
Which case? The one we talked about yesterday. By the way, thank you very much. That was more than gracious of you. And the only thing is, I just enjoyed talking to dentists, so I'm just happy to have you guys here. I understand everybody here is an orthodontist, correct?
Yes, sir. And if everybody can do me a favor, just if you can, you know what? I'm gonna mute everybody. Just give me a second here, just because there's a lot of noise coming in the back. So everybody's now muted. Dr. Menchel, I'm going to unmute you if I can find you. So give me just a second. Where are you? I can't find you. You're under, there you are. Okay. So Dr. Menchel, you are now unmuted. So let's see if can everybody hear him okay when he talks?
Can you hear me? Was that a yes?
Yeah. Yeah, thumbs up.
Okay. You wanted me to start with I can hear you okay too, right, Glenn?
Yeah. Yeah.
Okay, great. So,
and some background, we spoke yesterday about a case, right? Yesterday he said to me, what do you really want to talk about? And we had a discussion. And so, of course, he dove into the literature related to occlusion and ortho and distraction, osteogenesis. And I told him that for the most part, most orthodontists don't get a lot of training in TMD. And I felt that it was important for us to get a sense of where is that line where we should comfortably treat, and on the other side, we should comfortably refer. I know where my line is, but he then showed me a case and sent me some literature, and all of it is really good. And so with that, I'll leave it to you, Dr. Menchel.
Well, okay, but let me show you a case, and this was also an article I did for JADA, and this applies to all dentists on this case. And this is a simple case, which actually every dentist should be able to treat, but which you also will get from your refers also. And it illustrates some really very simple points. I'm gonna, let me see, share screen. Okay, so that's now working, correct? Can you see my screen, right?
Not yet. Well, I can.
Share screen, okay, hold on. All
there
right.
we go.
So we're up there, right? You can
Yes,
see
sir.
that? Okay, so let's see how this works. Okay, so here's a really simple case. This is a 35-year-old woman who was playing with her infant, and the infant popped her in the chin. You know how they can raise their head up, popped her in the chin, and she began to get severe pain in front of the right ear where the TM joint was, and she couldn't, she felt like her bite had shifted, and she was in a lot of pain. So she went to her dentist, good dentist, and she already had a bite splint from him, and he said, just, you know, wear your bite splint and we'll see what happens. Well, she wore the bite splint and it didn't help at all. So he was concerned about this. He referred her to me. And this is how she appeared. My mouse isn't working, but that's fine. So here's how the woman came in. If you'll notice, she had a midline shift to the left. She had a posterior open bite on the right side. And I start all of my lectures, and whether they're oral surgeons, orthodontists, general dentists, prosthodontists, with this one example, because it illustrates, you know, what a simple problem, or what I perceive as a simple problem, can get crazy when these patients appear to dentist's office. So when you look at this case, by the way, 35-year-old woman, severe pain over the right joint, this type of bite shift, wore a splint, didn't help her at all. Had no previous history of clicking, popping. She had no, you know, as far as she was concerned, she had a history of ortho. And if you take a look here, I ask the audience, if this patient was referred to you, one of the questions they ask general dentists is, what would you do? And most general dentists would refer this case. There's really no need to, because any dentist should be able to handle this case. So assuming the Panorex is normal, and you look at this case and you see the midline shift, anybody, I'd like to throw it open to you really quickly to answer. Anybody see what they think may be going on in this case?
And I'm unmuting everybody. So if you have a loud background, I'm asking you to please mute yourself, okay?
Okay.
So
Just look at this case. Very simple. He's in a lot of pain, posterior open bite right side, midline shift. Opening was limited. And again, I said imaging is normal here. No real past history of TMD, and she's a Bruxer. So what I try to emphasize to all of my students is you can't treat anything unless you can diagnose it. So other than TMD or TMJ, what do you really think is going on here? Number one, how many of you think this is a joint problem? How many of you think this is a muscle problem? Or how many of you think it's a combined joint and muscle problem, etiology-wise? Anybody think this is, if you can raise your hands, I can see you. Anybody think this is a joint
one more
problem?
time? Can you tell us what her symptoms are currently and what you found, if you don't mind, one more time?
Popped in the jaw, severe pain of the right joint, right preauricular area, limited opening, no previous history of any significant TMD, no joint sounds, and imaging is normal. Hard imaging is normal. Posterior open bite right side, midline shift to the left.
How is she on loading in CR?
First of all, let's stop it right there. There is no CR here, okay?
Okay.
So she's in pain. Any loading test this patient will be in pain.
Okay. Thank you.
We can talk about joint loading at the end too.
Right.
So is this, I'm kind of leading up to, this is a joint problem, okay?
Right,
this is specifically a joint issue. Now, we can discuss why, but in any joint issue, as an orthopedic finding, if you have a joint that is tender or painful, that joint will innervate the muscles that move that joint to be painful and also cause those muscles to go into spasm. So you will recognize that these muscles associated with the right masseter, the right temporalis are tender, and the muscles of mastication are in spasm. And I'm really getting ahead of myself. So before I go on to the next slide, everybody understand that this is a joint issue and should be dealt with as a joint issue, okay? Here's the kicker. When I present this slide, and this is a more sophisticated audience, when I put this slide here and I ask the audience, how many people feel that there's an occlusal etiology, that this patient has an occlusal problem that caused the joint pain, I almost unanimously get the audience to say, oh yeah, this is all caused by your occlusion. So do you understand as a group, and I'm getting ahead of myself, I'm going quickly tonight, you understand that this is not an occlusal issue? Anybody question that?
No.
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 Nope.
No.
Nope.
Do you understand? So you understand it's not an occlusal issue, correct?
Correct.
Yes.
Here's the scary part. Because of previous history of teaching and philosophies of TMD, I will get patients like this, where a dentist looks at this and say, oh, your bite's off. You have eccentric relation prematurity. You're hitting on the left side. And I have had patients like this that have been equilibrated down until they touched on the right side. Okay, let's see what's wrong with that, okay? So again, case history of just repeating. She has a present splint for bruxism, okay? Imaging normal. So this is the treatment of an uncomplicated patient. The diagnosis here is an inflamed joint. It's got a sprained joint, a sprained right joint. It's called capsulitis. So let's take a look at the schematic, and there's 4 determinants here. Okay, my mouse isn't working, so I'll just describe it. On the upper left side, you see a schematic of the joint, and this is before the patient was hit. And the joint is centered. You see that the disc on top of the joint, the posterior band is on top of the condyle where it's supposed to be. Retrodiscal tissue is posterior to that. Lateral pterygoid muscles in front. I'm sorry, I can't point everything out here. So that's where the joint is before the lady was injured. Posterior teeth are in contact. Take a look at the anterior determinants and you see where the overbite-overjet relationship is. And if you look on the lower left where you see the frontal view, her midline is on. So now what happens is this patient gets popped in the jaw and the joint swells. The retrodiscal tissue swells. You get inflammation or edema. what happens is you get a posterior open bite, you get a decreased anterior overbite, and if the patient had some overjet, you would also get a decreased overjet. And if you look at the lower left, the patient now has a midline shift to the left. I'm going to go back. That's the patient before. That's the patient after. That's the patient before. That's the patient after. Okay, so moving on. And also you get muscle spasm, and in this case, it's a lateral pterygoid, which holds the joint forward. Glenn, that's why if you try to load this joint, okay, and this is why you go back to the concept of bimanual manipulation to load this joint, it just doesn't apply.
Gotcha.
The better way to load this joint is to have the patient manually bite down. Now, this concept that Dawson and Pankey have, and I very much respect those institutions, this concept came about from the concept of orthopedics. If somebody has a sprained knee or somebody has a sprained elbow or a shoulder, orthopedic surgeons are taught in school for them to manually grab that limb or joint and to push up on it. There's a problem when you come to the TM joint. The problem with the TM joint is the sliding joint, and it's not in socket. Those other joints are in socket. So you can't, in these cases, you can't possibly get that joint back. You can't go up against that lateral pterygoid co-contraction. You're never going to be able to significantly load test this joint the way Dawson or Pankey describe it. As a matter of fact, you'll probably get less pain from trying to do bimanual manipulation on this joint than if you just had the patient bite on their back teeth. Because as soon as they begin to bite on their back teeth, then you get some release of the lateral pterygoid and the joint seats. So that's why I just mentioned the centriculation. Everybody with me? And if I'm going too quick, let me know.
Question, Hal?
Yeah.
Real quick.
Yeah.
So if this patient came into any of our offices and we'd never met her before,
right.
She says, you know, I'm here for an orthodontic consultation. My dentist sent me. And by the way, last week I got hit in the jaw and my left side's been killing me. And the midline is off to the right? Because that's what we'd expect.
Correct.
Her overjet has been decreased relative to something we've never seen before, right?
Yeah, you've never seen the patient before.
I've never seen her before. And she's not really complaining of it. It's sort of like, not subclinical, but it's not a day-to-day big issue for her. And so during the course of my exam, I noticed, oh, she's a little bit sore. She's mentioning she's rubbing over here. Where do I go from there, or are you going to touch on that?
Well, I don't think she'd be seeing you for, in all practicality, this is an acute issue. This patient's in significant pain. I don't think that I think that routine dentistry at this point would probably be deferred, even if she had the appointment, until her pain's under control. So I don't think you can see her.
Okay, so this is going to...
Let's say the more likely case is that she went to her general dentist who didn't know what to do and referred her to you.
Right.
More likely.
But what you're saying essentially is this woman is going to be, this sort of presentation is going to be significant pain. This is not going to be, I banged myself, I'm a little sore, I've been taking Advil and it's all better. This is going to be, by the way, I can barely open, it's killing me. What can you do to help me? Correct. Gotcha. Okay, thank you.
Okay. So everybody understands these determinants. Good. And just to illustrate that again on a schematic by a TMJ tutor, you have the patient with their teeth together, the joints lined up, the disc is in position, you get inflammation behind the joint, and that's what happens. Okay. And you get the open bite. So in this person, the treatment objectives with this person, obviously to reduce pain, but what you want to do is you want to support the right joint to reduce load. You want to reduce inflammation, and you want to manage bruxism and pain. Remember, this lady was wearing a splint, so we know that she was a bruxer. And I want to get back down to this right away. You do not want to manage her occlusion at this point with any kind of occlusal therapy in this acute patient. And as amazing as that sounds, is that dentists focus on TMD as being an occlusal disease, and they're immediately looking for something to be wrong with the occlusion. So this is the way I load test, and we can talk about this. I'm going to ask the group a simple question. Hopefully you all have good occlusions because you're orthodontists, right? If you bite down on your back teeth, so your back teeth are in contact, and you clench firmly, not as hard as you can, but you clench very firmly, what takes the force? The teeth Or if you put your finger up in front of your ear and the joint. In other words, squeeze together. Where is the force? On your teeth or on the joint? Answer that for me, somebody.
I'm not allowed because you've asked that to me in Florida, and I know the answer.
Okay. Anybody else? Where do you feel the force? In your teeth or in the joint?
Joint.
Teeth.
Kind of both.
Teeth. Yeah, you may feel, actually what you're feeling in the joint is about 15% of the force. If you go through biomechanical, you go through the principles of biomechanics and so on. When you have good posterior support, teeth protect the joint. Anybody here box or do any kind of amateur boxing or anything like that? I know the woman, she shook her head. Okay. The first thing you're taught as a boxer, especially if you don't have a mouth guard in, is if you're going to take a punch, put your teeth together and clench tightly before you get that punch. Why? Because it protects your jaw from being fractured. So when I load test a person, in this case with this person, they had a posterior open bite on the right side. Therefore, when they tried to bite down, the teeth were not touching. All the load goes to the joint. So what I did very simply is take a bite stick, and it could have been a tongue blade, but in this case, I used a bite stick, and I had the patient bite between the second molars. Now, this is what's counterintuitive to a lot of people. Would you think that if the patient bites like that, having horrible pain on the right side, the joint's inflamed, you put this stick between their back teeth and had them bite down hard, would you think they'd have more pain or less pain? How many people think they'd have more pain?
You would think.
How many, you can raise your hands. How many think they would have more pain?
Well, I'm going to say
Nobody.
I would think that, but
Okay, they don't.
clearly
They
the
have
answer
less
is not.
Okay. You'll find in patients with an inflamed joint or a hot joint that if you put a stick between their back teeth, all the load goes to the stick. You're now establishing posterior contact, and the patient will have greatly reduced pain. And here's the key. The more distal you put the separator or the stick between the teeth and have them bite down, the less pain they have. If you put the stick between the front teeth, they'll get some reduction of pain. Anybody know why?
Nasotrigeminal inhibition reflex?
Somewhat. You're talking about like an NTI. Yeah, you're going to get reduced. You're going to get reduced muscle contraction. However, the joint's still going to be loaded more than if you unload it by putting something in between the teeth and the back. And Glenn, I don't want to get into this now, but also by putting a flat plane between the teeth, you're also, there's a created constriction of envelope of function here.
Yeah.
Where the patient now is just mainly hitting those front teeth so that as she bites down, she's getting some distalization of the jaw. So when you put anything flat between the teeth, that constriction is going to go away and the patient's going to feel less pain. So this is how I load test my patients. First, I have them bite down naturally on their teeth, which releases lateral pterygoid to some extent. And then if that hurts or they're feeling any significant pain, then I take a stick, put it between their back teeth, and it usually relieves any symptoms that they have. Go ahead, Glenn.
And that would be the reason, I suspect, why we were taught years ago that an NTI appliance is contraindicated in joint-related pain, but it is only supposed to be short-term for muscle pain, correct?
It is, correct.
Okay.
Correct. Any questions here so far from anybody?
There is a question from Akash. He asks, is popping and clicking on opening with no pain a problem? And how do you treat, besides noting it, proceeding with ortho and monitoring it as a jaw location on wide, how do you treat it besides noting it, proceeding with ortho and monitoring it? And is jaw dislocation on wide opening a problem? Again, it doesn't have to be answered right now because I don't think that relates to this problem. And we can save it till the end if you prefer.
I'm going to answer it quickly and then I'll explain why later. Painless clicking and popping with no dysfunction and with normal imaging does not necessarily have to be treated. I would look at the patient to make sure that they're not, typically gum chewing, leaning on their chin, biting their fingernails. I would control oral habits. I would reassure the patient. I would document that the click and pop was there, and then I'd go ahead and do ortho. As far as locking, now we have to define something here. when the joint goes beyond the eminence, there's two things that can happen. You can sublux, or you can dislocate. What was the question? So, dislocation?
He uses the term dislocation, but I suspect that he's using it interchangeably with subluxation.
Okay, let's define those terms because it's really important. Some people sublux normally every single day of their life. They may have a shallow eminence or a shallow temporal bone, but every time they open wide, the joint goes further than it should. It goes ahead of the eminence and then superior. But as soon as they close, the joint goes back again. So that's a subluxation, where they're opening beyond where they should. They may have loose ligaments, hypermobility, whatever you want to call it. A dislocation is when the joint goes ahead of the eminence and locks there. Okay, that's a different kind. That's a different kind of term, and that needs to be treated very often. However, most people, and you guys should know how to do this, how to reduce that dislocation. In terms of ortho, if somebody's constantly dislocating, I think that needs to be addressed, but we'll talk about that later. But subluxation, I wouldn't overly worry about that, as I wouldn't worry about painless clicks and pops. Any other questions?
Al,
Yeah.
if I could just follow up, you mentioned one word or two words, proper. If the joint looks good on imaging, can you explain real quickly that patient comes in with what he talked about, popping, clicking? What imaging would you suggest we have in order to make that decision that the popping and clicking is not something we should be worried about?
Panorex is just fine. A good quality digital Panorex should be fine. If you're suspicious, and those, how many of you, do any of you have CBCTs? CBCT is probably more of a gold standard for bony contour. So, you know, if there were any bony changes, you would see it more on CT, but generally Panorex is adequate, especially the modern Panorexes.
Okay, thank you.
Okay.
No other questions here.
Yeah. No other questions?
If anybody has one, please type it to me, but I don't see any here.
Okay.
Oh, hold on. From Leon. How soon does the muscle spasm occur when a patient gets capsulitis?
Almost immediately. So then they go from a normal opening, which is between 45 and 55. As soon as they get active acute inflammation in the joint, the sensory input takes over, and the spasm is almost immediate. Just like if you whacked your hand or arm and it began to swell, all of a sudden you can't move it, okay? Everybody think, oh, I can't move it, it's broken. You can't move it because this is a law called Hilton's law that I just gave, an orthopedic law, saying that when a joint is injured or inflamed, it'll cause the muscles that move the joint to go into pain and to spasm.
So the capsulitis you're describing comes solely from an acute sharp blow, or could our placement of any particular sort of appliance or anything cause a capsulitis as well?
You can get a capsulitis from overextension of the jaw too, where you tear the ligaments or or the capsule part of the joint. In other words, if you stretch that connective tissue, you stretch the ligaments, you could also get a capsulitis. It doesn't just have to be a compressive blow.
But is there anything that
extreme lateral move where, you know, somebody's trying to extract an upper third molar and the jaw's, you know, moving way to the right or the left. Anything where there's excessive forces on the joint could theoretically cause an acute capsulitis.
Okay, so potentially, in theory, there is a possibility with certain appliances that we could give somebody where we could induce a capsulitis and someone could come to us complaining of this exact situation.
I think it'd be rare. You really have to put an awful lot of force on something in order to do that. I don't think you overly have to worry about that.
Okay.
On the right side of the splint, I want you to look at when we load test the joint. I have the patient bite on the side that's painful. It hurts. I put the separator between the back teeth. Now, what I also do in a person where the posterior bite is not so obvious is I really want to load that joint. So what I do is I put a separator on the contralateral side, and this is called Mahan's sign, where the patient now bites on the contralateral side. You now have a created posterior open bite on the side that's painful, and now the joint is really painful when this person bites down because you're getting direct load to the joint. And we call this Mahan's sign after Dr. Parker Mahan, who I was taught this when I went to the University of Florida, Gainesville. And what I want to emphasize to you is those of you who do bimanual manipulation, you really are getting too much lateral pterygoid pushback in order to really tell if the joint hurts or not. And the concept there, you're supposed to ask the patient if having any tension or tightness. Of course they're going to have tension or tightness because the lateral pterygoid is reflexing against your push. The other thing that I don't like about bimanual manipulation with the mouth open is if they do have a significant internal derangement where you could end up actually hurting the patient with excessive forces and actually having the patient go into a closed lock where they can't open after you've manipulated, which I have seen for some people. There's no reason to do that bimanual manipulation loading test. Okay.
Thank you.
All right. This, I'm just showing what my splints look like. I'm going to get back to this. Let's go ahead, okay? So this is this lady who had a decently made, this is a lower splint. I want you to notice at her initial presentation, I had her come in with her splint. When she bit down, that the occlusal issues were duplicated in the splint. When she bit down, I'm just tapping this out with AccuFilm. You notice that the lady hit only on the left side of the splint. What I did is immediately, because the splint was there, I adjusted it down so that she had equal posterior contact both sides. Can you see that? And she was very comfortable almost immediately. And we gave her some adjunctive care, which I'll talk about. I sent her home like that. And then I saw the patient 2 weeks later. And I want you to look at where the splint is now. That's how she presented. Because what happened here is that the inflammation went down in the joint settled back, and where I had adjusted the splint, it was now heavy on the right side because the joint had seated back and she was comfortable. Now, I want you to imagine what would have happened if a dentist had equilibrated the left side to get the right side to touch. The patient would have felt comfortable, but now when they came back and now they're comfortable, guess what? Their teeth aren't touching on the left side because they were equilibrated down. And that's why, in general, this is an acute case. In general, you don't ever want to do occlusal therapy. And you guys should know this on any kind of patient, unless you know that the bite is stable. And we'll discuss how you can do that later if we, again, given the time. Everybody understand why this was heavy on the right side? Got it? Any questions? I'm not, this is a new format to me. So if I'm going too fast or going too slow, you guys let me know. All right?
Great. And there's no questions on this end.
Okay. So let's continue on. All right. I skipped something there. Okay. Let's go past this. Maybe get back. These are kind of splints I use on kids. Okay. So what else did I do for this lady? Just common sense. I want to take the forces off the joint. Soft diet. Moist heat is wrong. I should change that slide. In acute inflammation, you want to do ice, at least for the first 72 hours, and then go to moist heat after that. You want to do ice, that's wrong. Muscle relaxer, I use 5 milligrams of Flexeril for patients. You should be able to use that. It's a very safe medication. It helps the patient sleep at night, and it reduces muscle spasms. Typical orthopedic treatment. Anti-inflammatories, I happen to use naproxen 500 milligrams at night, BID for 2 weeks. And in patient that's really inflamed, where she's in severe pain, where you almost can't touch the joint, I'll give the patient a medral dose pack. And by the way, if the patient's not a bruxer, they just had the capsulitis, even with a severe pain, I may not put them in a splint. There's not necessarily necessity for that. There is some, has anybody ever heard of an aqualizer? Okay. Aqualizer is a disposable splint you can get, which basically is a water pump that goes, and it has 2 pads in the back, and you put this in the patient's mouth and you get immediate posterior support and relief of the joint. It's not ideal, but it's not a bad way to go. Another thing that's become popular, has anybody heard of Brad Eli's Quick Splint? Okay, look up Quick Splint online. Brad Eli, who's a colleague of mine in AAOP, it's a tray that goes back behind the cuspid, it's almost to the first premolar. You put it in the mouth, you put in a polyvinyl impression material, you seat it up, and it acts as an instant splint for the patient. And it can be helpful in cases like this. Again, not ideal because you're not getting as far as posterior as you want, but just for a quick fix, quick splint, aqualizer are just fine. And occlusal adjustment is contraindicated. What happens to this person over a period of time is as the retrodiscal tissue, which is posterior to the joint, begins to inflammation is reduced, the joint settles back in. And if we look at this patient, here's the initial presentation, and there she is 2 weeks later. Okay, simple case. Everybody should be able to treat this. My main point here is that you just got to know what the diagnosis is. And the diagnosis is not TMJ and occlusal disease. And that's what I see too much. I'm going to get out of here for a second, and I want to go to the case that I showed to Glenn. Okay, let's go. Okay. This is a 12-year-old girl who originally, she had a palatal expander when she was 8 years old. Or the orthodontist that she was seeing was ready to go ahead and do orthodontics on her until he saw what her occlusion was. I want you to take a look here and notice the facial asymmetry with the chin off to the left. Let's also take a look at her occlusion here. Remember, palatal expander at age roughly 8 or 9, and this is how the occlusion presented. Midline shift, significant midline shift to the left, crossbite in the left cuspid area. If you take a look at the lower occlusion, you see that the whole right side is class 3 and that the cuspid is shifted around completely. Okay, so this patient was in pain, left side preauricular jaw pain, and when she came to me, and when she came to that orthodontist, he told her that as soon as he got her in braces, that it would help her pain, that this was a bite problem, and he would be able to fix this. Wasn't happy with that. So then I think whatever treatment he began wasn't successful. She went to a different orthodontist who referred her to me. So without any imaging here, with this kind of presentation, I want to throw it back to you guys. Anybody know what any suspicions here of what's going on? And again, I want to start with always, is this a joint issue or is this a muscle issue? Anybody want to answer that question really quickly?
I've unmuted everybody.
CRCO discrepancy shift causing.
Okay. Is there a CRCO discrepancy? No, she closes here. She doesn't hit and shift that way.
Somebody here wrote functional shift to the left.
Okay, no, there's no functional shift. If you gently, now this case, you gently open and close her, you manipulate her, she does not hit and functionally shift to the left, no.
Possible condylar hypoplasia?
Great call. Yes.
She's a teenage female. Those are the typical signs for condylar hypoplasia. I could be wrong.
No, I like that. There is a resultant condylar hypoplasia here, but it resulted from something else. If I did this slide right, I'm not sure what's coming up next. Let's take a look. So I said, is this inadequate transverse jaw relationship? Anybody think it's that?
No.
No.
Okay, because she was expanded. Right, she was expanded. Okay.
Bolton discrepancy?
Say again?
No.
Is there a Bolton discrepancy as well?
Oh, you're talking ortho too much to me.
Yeah.
Okay. Right.
He's asking.
Was this related to growth and development? Yes. Ventriculation interference? No. Habit formation where she just closes that way? No.
Was there ever any sort of neoplasm or any issue in the condyle?
There could be. That's why you have to image. Okay? There could be. Sure. Okay? Yeah, this could be a big right side joint pushing the jaw to the left. There's no question. Okay, so what this is related to growth and development. It is TMD. So let's take a look at the pan. If you can see it, you know that you guys, my pictures are blocking out the left side, but I have an arrow there. And if you can read a pan fairly well, you can see that that joint just does not look normal. It looks flattened. And I'll show you the CBCT on this joint in a second. More importantly, I want you to notice, and you can see it on the right side also, that that's the mastoid process. It's very radiopaque. And this is an indication that you see very often in children who have had repeated otitis media infections, middle ear infections. And the infection spreads to the mastoid process. You get a mastoiditis. And as they get older, the mastoid bone begins to look like that. This is radiopaque. And here's the CBCT. You can see that the right joint is fairly normal. And take a look at the left joint, how it's completely dished out. And if you look at even at this size, it is hypoplastic, it's smaller. This is arthritis of the left TMJ. And this arthritis, in all probability, and I have seen a few dozen of these cases, was caused as septic arthritis from middle ear infections from the age of birth to age 3. Glenn, you said you've seen this now since I taught you about this?
Yeah, when you taught me, I always ask now, have they had ear tubes?
And have you run into that? By the way, they would normally either have had to have an eardrum perforation or tubes, and I'll show you why in a second. Have you, but you've seen one bum joint on patients like this?
Yeah, I've seen asymmetric facial appearances, and I've taken a look at the pan and seen problems. And the first question I ask them is, has this child had repeated ear infections and have they had tubes? And the parents almost faint when they hear me ask that question because nobody's ever put it together. Thanks to you.
Okay. So, by the way, I want to also distinguish, this is not a microsomial, not saying it right, hemifacial microsomia, okay? And how can you tell that by just looking at the patient's face really quickly?
Everything else.
How do you know it's not a hemifacial? Just looking at their face.
The face
Soft tissue is normal.
Right, zygoma is normal. Okay, you're going to see differences between the maxilla and the zygoma in a hemifacial. So, and there's no issues here in terms of that. This is strictly joint. Okay, so here's what goes on. Okay, I want you to look where it says HF because I can't point things out on this slide. Anyway, where HF is, that's Huschke's foramen. That EAC is the external auditory canal with the ear out to the right. That little passageway at about 10 o'clock where it says HF is where the eardrum is, and the middle ear is behind that. And then you see HF, this is in an infant, CT of an infant, of the ear. Right here, in between HF and EAC, where I have that arrow, that is a very thin membrane and a foramen that's left over from development called Huschke's foramen. When you let pus out of the middle ear, it comes out of the middle ear, it goes through that membrane because it's very acidic, it eats through there, and it goes right into the condylar space and infects the condyle, causing a septic arthritis. So that's the mechanism of this. So I follow this patient through now. She's now 19 years old. And I want you to look at the development of this from 2011 until 2017. So here's where she presented 2011. Here she is in 2013. And she sent me this picture from her phone. So the angulation's not that great. But in my opinion, I don't think there's been a huge change between 2013 and 2017. She was 15 or 16 in 2013. She's 19 now. So what I'm saying here is that she probably was pretty close to full growth in 2013, and I don't see that much change. Anybody disagree with me? Are you seeing a big change still, or look almost the same from 13 to 17? It's hard, because of the angulation. You agree? Okay. So let's take a look at her face again in 2011. Let's take a look at her face in 2013. And then let's take a look at her face with the picture she recently sent to me. Now, definitely the facial asymmetry increased between 2011 and 2013. Do you feel it's increased that much more to 2017? It's hard to tell. What do you think?
No,
Anybody have an opinion?
no. Looks about the same.
Okay. So now we get into the big issues. The girl's now, it's 2011. This girl's presented to you. She's in pain. I'm going to tell you that since the first thing I did is just conservative TMG therapy. We did imaging. I made a diagnosis of arthritis, unilateral arthritis in this child related to ear infections. I put her in a splint. I gave her some mild anti-inflammatories. Since the first week I've seen her, from 2011, 2017, she's had no pain. So the pain issues were solved very, very quickly, just with a properly adjusted bite splint, very similar to what I showed you. All I did is give her good support all the way around, good posterior support. It took the load off the joint, and she's been just fine. Okay, so now we go back to 2011, and I think you guys already know the answer here. Would you have treated, anybody here have treated this child in 2011? Anybody? And what's wrong with treating her in 2011?
Unpredictable growth.
Yep.
Okay. So what's your treatment plan? Let's come up with a treatment. What's your treatment plan for this patient? We got a splint in, she's comfortable.
Is there any pressure from the parents to treat her? Are they dying to treat this girl, or do we have all day long to wait? Can we wait years?
I don't remember.
Okay.
I don't remember that there was any pressure here. That's why I sent you that article, but I don't know if I want to bring that up again, okay?
If you bring that article up, Hal, it would certainly be good discussion, but I would save that as the cherry on top.
Okay. I gave Glenn an article about actually treating someone like this with distraction osteogenesis.
Or bring it up right now.
Huh?
Or just bring it up right now.
I'm not doing it. We can talk about that, or you can talk to Glenn about that later, okay? Point here is that here's what you have to do in any treatment plan with an arthritic case, any kind of arthritic case, whether it's rheumatoid arthritis, juvenile idiopathic arthritis, septic arthritis. What you have to do is to determine that you have bite and joint stability. In other words, that the jaw has settled into a final resting place where you can now go ahead and do occlusal therapy. So what's the occlusal therapy for this kid? It's hard for me not to interact with you, but obviously she needs orthodontics. Okay, the second thing is, in order to correct that facial midline, I guess you could try to do bone. I mean, some people talk about bone plates, things like that. But as far as I know, in my meager knowledge of orthodontic surgery, this is a two-jaw case because she has an occlusal cant up to the left, unless she wants to live with a facial asymmetry. So how do you determine bite stability? Well, you do your imaging over time. A CBCT, you can measure changes in the bone. But the absolute best way to do it, other than taking good records, is to just follow the patient on the splint. Because if the jaw keeps shifting from month to month, from year to year, that means that there's no stability here and you can't go ahead and treat this patient. So that's it. I mainly determined from the splint, my initial records, when everything is settled in here, this kid's got no pain. I don't think there's any, that joint is fairly stable. She's 2017, and I think we're ready to go ahead and treat her. Any questions?
Yeah, Doug Shaw has a question. His hand is raised.
Okay.
Yeah, my question is, would you ever get, from the same etiology, would you ever get this facial asymmetry, but without that arthritic pain? I mean, when you see facial asymmetries like this and you see that condyle there,
it could be what? Were you the one that said it could be condylar hyperplasia?
I did not say that.
Yeah, it could be a joint that's not growing. You know, the joint could have been traumatized. It doesn't mean it got arthritic. It means it was just traumatized or injured to the point where it didn't grow. Or there was some kind of, you know, a genetic predisposition. Who knows, you know, but you don't have to have pain. Not at all.
There's another
The other thing here is you could have a condylar hyperplasia or something growing on the right side that would end up giving you the same kind of facial asymmetry over time. Like
How there's two questions. One is from Bel Air Mobile. Is this a full-time splint they're wearing 24/7?
Okay, let's take a break. Yeah, let's go all over the place. That's a great question in general. There are people who do what I do, who advocate that their patients should wear the splint 24/7 for 2 to 3 months after they treat the patient. Well, let's assuming that the patient bruxes, and not all patients clench or grind, but let's assume that they all do. There's a big difference between nocturnal bruxism and daytime bruxism. Daytime bruxism is habit formation for the most part. So most of the damage that's done to the joints, most of the load that's put on the joints in most TMD patients is done at night. So I want all my patients to wear the splint at night. If they're more comfortable during the day, especially when the pain's in the acute phase and they want to put the splint in during the day to wear it to make them more comfortable, that's fine with me. I don't even care. I mean, I've had patients in long-term splint wear too, with different diagnoses. There's not going to be any harm to the muscles or the joints if somebody wore a splint 24/7. But in general, I don't advocate it. And in general, you're going to get really poor compliance if you tell a patient to do that. So that answered that question, I hope. Nocturnal, daytime bruxism, we do classical conditioning techniques to teach the patient to keep their teeth apart. And over time, we can usually train them within 48 to 72 hours to stop clenching during the day, unless there's some neurological or medical issue.
Okay. There's two other questions. One, Jeff Lee, you're up next. I saw your hand was up.
Hi. So my question is, I'm not too fond of diagnosing TMD or these related conditions. Do you think it's wise that we refer to a TMJ specialist for some, like, because I can't differentiate between, whether it's a condylar hyperplasia on one side or a condylar hypoplasia on the other, or, like, you have to, obviously it's a bunch of questions and answers with diagnosis and everything like that. But in regards to this specific case that you presented here, would you get a rheumatologist or some kind of physician to basically, or some kind of specialist to basically give us the A-OK that, hey, it's no longer a problem to worry about with the joint, continue with orthodontic treatment, or should we, I don't know, it's sort of
that's a great question. And I really, I'm not into a completely organized presentation tonight. I'm really glad you asked that, okay? Number one, you could refer this to an oral surgeon for him to diagnose any kind of arthritis or problem with a joint. The problem is that most oral surgeons will diagnose it and then they'll refer the patient to me. There are very few oral surgeons who want to get involved with splint therapy and get involved with following the patient. So most of my referrals on a patient like this, a lot of them will come from oral surgeons after they've been sent to them. So the patient will end up with me, whether they come through an oral surgeon or they come through me. Either way, one of us will diagnose the problem adequately and be able to work and coordinate treatment with you. The second question you asked is a great question because I didn't mention it. Any case like this, even though I'm fairly sure this is unilateral, you want to get the patient to rheumatology and to get what's called a rheumatoid panel done for the patient to make sure that there is no juvenile idiopathic or rheumatoid kind of arthritic condition here. If a patient is diagnosed with rheumatoid arthritis, no matter what you do, there's a high likelihood that patient is going to relapse over time. So you're never going to get stability.
Cool, thank you.
Ask what the ultimate treatment for that patient is. It's scary. But in a severe rheumatoid patient with rheumatoid arthritis, standard of care at this point is alloplastic joints or metal joints.
Thank you so much.
Great.
I'm going to add one more thing to that. One of my friends is Lou Mercuri, who does alloplastic joints. He invented what's called the TMJ Concepts joint, which is a metal joint. And Lou kind of turned me around because I was horrified at having to do this to my patients. But I kind of had an epiphany when I met Lou a few years ago, and he was president of the American Society of TMJ Surgeons. He showed me a picture, and I wish I had it. He had a 9-year-old kid with a hemifacial microsomia. And he did the reconstruction on the left side of the kid with a metal joint at 9 years old. He showed me a 10-year follow-up of that patient. They grew normally. You would never see that they had any kind of issue, and the joint was in place 10 years later. Kind of cool.
Wow. Another question here that was typed to me from Leon. He said, I often find facial asymmetry with the chin deviated for various reasons. Do you proceed with this protocol, wait and monitor, only when you see condylar deformation?
You could just have a kid with, no, not necessarily. I mean, if both joints look healthy, I think it's probably worth to do a CBCT just to rule out any bony changes. But some people just have longer ramuses than others. One side shorter than the other. That's just the way they developed. I wouldn't worry about that. You might want to take a look at some pictures, like kindergarten pictures or elementary school pictures or whatever, go back and look and see what the chin looks like. But I wouldn't say you have to do this protocol. If there's pain, clicking, popping, dysfunction, positive imaging, yeah. I think the next slide shows, let's see where I am here. Okay, pain management, here I go. Baseline documentation, imaging, records, rheumatology should be done here. And I'm just showing that people can be successful in life, although he just had recent problems. This is Brian Williams with the facial asymmetry. So yeah, I mean, I wouldn't make too much of a facial asymmetry. I mean, if it's severe, you might want to go a little bit more into the history, but a lot of times they're just stable.
Yeah, the reason I ask about this is we see a lot of asymmetries in our patients, but you know, if we always follow up for 5 years, then it makes it very difficult to start a case. And so, you know, we kind of have to draw a line of, okay, this obviously you have joint deformation, and therefore you have to delay. So I think that would be, you know, you have some sort of evidence showing that you have to delay a treatment. But if you don't, the joint seems fine, either from a PAN or a CBCT, then, you know, from my point of view, I would just go ahead and start orthodontic treatment.
I agree. I don't think there's an issue with that. The other thing was, let's say that that little girl I showed you had really, you know, significant anterior crowding. You know, there's nothing wrong once she's out of pain to go ahead and do your level and aligning. You know, I mean, give her a nice smile while you're waiting. There's nothing wrong with that. I mean, you're going to probably have to go in and tweak things later. And by the way, she can wear, you know, she can wear the splint on the opposing arch while you're doing that. And you can do one arch at a time if you want. You know, but they don't, especially if they're going through a very psychological, psychosocial phase of, you know, beginning high school, late middle school, and they feel their teeth are all snaggled up. Once the pain's under control, you know, you can level in line. I don't see any issue with that, as long as the patient realizes this isn't the final orthodontic treatment.
I had a quick question earlier. Glenn didn't get to see it. Do you prefer upper or lower splints?
It depends on the patient. That's another long explanation. To cut to the chase, about 80% of the splints I do are lowers, mainly for patient comfort, because there are some patients that want to wear them during the day. They tolerate them better. I can control the tongue space better. They can actually speak with them. So that's one reason. So about 70 or 80% of mine are lowers. Secondly, is that when you have a malocclusion, especially in class 2 patients, a lot of times you'll get a step or a bilevel bite on the lower in the mandible. Do you know what I'm talking about? Okay, so therefore, if you do an upper splint against that, you end up with kind of a roller coaster where, you know, the case is hanging down in the back. The splint, it's not an even occlusal plane. So by doing a lower splint, the upper plane is usually much flatter because the lower anterior teeth have erupted up behind the upper teeth or whatever, and I can get a much flatter plane by putting a splint on the lower teeth.
And how you always use full coverage splint is the question that was asked here.
I never say never and never say always, okay? I certainly recommend to anybody who's not doing a lot of TMJ, they use full coverage splints. Because if you use partial coverage splints, NTIs, things like that, you have a high likelihood that you're gonna get occlusal changes over time. I can't tell you how many patients I've seen with NTIs that end up with anterior open bites, patients with Gelb appliances where they're just posterior contact that end up with posterior open bites. So I almost always use posterior full coverage splints with good posterior contact.
And
do I ever use an NTI? Yeah, but there's a lot of explanation for that.
Yeah, and before I go on to the next question, I just wanted to say it's already 9 o'clock, and I promised you, you were kind enough to offer to do this, and I don't want to
keep going. I'm fine.
I know.
I got nothing to do but go to sleep, so.
So I don't want to keep you, again, too long. And by the way, everybody, with Dr. Menchel's permission, all of this is being recorded and put on our private YouTube channel. Is that okay with you, Dr. Menchel, so they can come back and watch it again?
Fine. As long as it doesn't get disseminated beyond the group, I'm fine with it.
Great, thank you. And before Doug asks his question, I mean, I've sat and listened to you for days, and I always learn something new. If I could get enough interest from the group, would you ever be interested in having us travel out to you and host a course for a day or something?
Right up my alley. Right now, I'm Inman Orthodontic Lab in Coral Springs. I don't know if any of you use them. Don, they used to be with Space Maintainers Lab, and now they're Inman. They're separate. They sponsor me. So what we've done, and I've done it from the groups at the school, and I coordinate this at the school. As I get 8 to 10 students, and I really prefer orthodontists, and we do a hands-on for a full day Friday, half day Saturday. So what I would do is do the didactic on Friday. You would give me models ahead of time. We would have a splint made by Inman. You would pair up, let's say there were 8 of you or 10 of you, you would pair up and put splints on each other. I would, you would see that, we would supervise that with my assistants, and it's a 2-day course, and it covers billing, fees, insurance, the whole bit, as well as going through anatomy and basic TMD information. Right now, the last time I did it, we were charging, I think it was $2,300 a student for the 2 days. I have a place for you to stay. I get a book of rooms at the Marriott, and there's food too. So, and the food's pretty good. It was pretty good last time.
I mean, if there's food,
question.
We prefer courses with food, so
okay.
It sounds like it might be up our alley.
Some food is there, yeah.
Okay, so Doug has had his hand up virtually for a while, so Doug, please.
Okay, I see you, Doug. Okay.
Hal, my question for you is in regards to functional shifts, and when we see these young kids coming in with posterior cross bites, with strong functional shifts, what is the long-term negative effects, both in condylar changes, disregarding the fact that it's much easier to expand at a young age because we can split the palate? What are the long-term negative effects on the condyles and the rami, and do you get that differential growth to set in permanently, causing facial asymmetries? That we look for in a herps, trying to get condyles to remodel and redirect the growth on that. What's your...
Okay, some of that question is above my pay grade, so I'm not going to go there because I'm not an orthodontist. If the patient has no pain, if they're not bruxing, if there's no forces on the joint, it's strictly an orthodontic treatment decision. Okay, just because you have a facial asymmetry doesn't mean you're going to have a TMD problem or a malocclusion or even a functional shift. On the other hand, these patients may not have the joints. If you have somebody with a facial asymmetry, and I don't want to comment on it now, I believe one joint is going to be taking more force than another. So there's that. So if there was a problem, it would tend to happen unilaterally. And you can't predict which joint that's going to be because you don't know how the patient's going to function, chew, and speak. But a lot of times with these kind of cases, if you see a TMD problem, it's usually a unilateral issue. It's not a bilateral issue because forces are being misdirected, by the functional shift. And beyond that, I'm not going to say a lot more because I don't think I have an evidence base to come up to give you accurate information on that.
Fair enough.
Okay.
Thank you.
Any other questions from anybody in the group right now? Because I
have another arthritic case I can zip through here with bone plates. Anybody do bone plates? Other than Glenn? Okay. So I'm going to go through this real quick. This is a 40-year-old lady, and she had bilateral TMJ arthritis with a resulting anterior open bite. I'm just showing you, I don't have a CBCT on this, but if you look, especially in the open and closed lateral TMJ view, you'll notice that the joints are, the right joint's just a little peg. The left joint's also deteriorated. That's her Ceph. You see the anterior open bite. This is how she presented. By the way, you notice that there was wear. These teeth were touching because these teeth are worn. There is wear on the anterior teeth. She was a bruxer. Again, what happens here is you have condylar erosion and you get the open bite with the auto rotation. The fulcrum around the auto rotation is always on the distobuccal cusp of the lower second molar, by the way, okay? So Normal joint position. You see the facial, normal facial height. This is what happens with a bilateral TMJ arthritis. You guys should know this. Here's the models. This is the way the patient came about. The interesting with this patient is that a lot of times this would have been an orthodontic case. But when they mounted models on her and they designed the case, and this was done with some of the new software, her AP was really good. So they decided to do, and you may have been with John when he did this case, Glenn, I'm not sure. This was done by John Marchetto. And by the way, I want you to notice in here, we did serology on this patient to rule out any kind of rheumatoid arthritis. We followed her with a splint. We established joint stability over a period of 12 months. We did man study models. We did all of this kind of stuff. She had a stable splint. Okay. If you notice, when the splint's not stable, this is an upper. The splint was adjusted to equal contact. Notice 2 months later on this patient that now she's hitting heavily, and this is an upper splint, so she's hitting heavily on the left side. So that joint is changing. Also could be reduced inflammation, but the joint was changing in this case. I just want to show you how we treated the case. John did bone plates on the upper, bone screws on the bottom. This is 2009. Patient was level and aligned. Bone screws, bone plates. That's the finished case. That's the start.
Is Steve the surgeon on this one?
Reimer. Yeah. Steve did the bone plates. Okay. So that's the start. That's the finish. This was not done non-surgically, if you want to count the bone plates as non-surgical. On the left, that's her with the pan starting. On the right, that's her finished. This case is amazing because she's now been stable for 11 to 5 years. I haven't even had to touch the case. She's been completely stable. So that's just a bone plate case. Here's metal joint replacements, just to show you what that looks like. This is a patient with an ankylosed joint. I'm not going to go through that. Hopefully you guys don't have to have that. Problems with, there's a ton more I can go through, but why don't I just take the time to finish up now? I can just give you guys, you must have some general questions. Obviously I can't do everything in an hour. So, and if you just want to throw some questions at me now, I'll be happy to do it. Or Glenn, if you want to direct it in a certain direction. Yeah,
I was just going to say, I was blessed to be able to be introduced to Dr. Menchel along with two other doctors, Dr. Reimer, Steve Reimer, who's an oral surgeon, one of the best trained, you'd agree, Hal, one of the best trained oral surgeons in the United States.
Yeah, I think he's top 10 or top 5.
And John Marchetto, who I almost I would have been practicing down the road from these guys if I stayed with John, who is arguably one of the best hands-on talented orthodontists you'll ever come across. And this group here has really brought bone plates to all of South Florida for class 3 correction, class 2 correction, unbelievable stuff. And Hal, I'm going to ask if I can get Steve or John on here one night just to go through some of those cases.
Okay.
But I know you could talk about this stuff for days. I have a question here. When you notice a jaw deviation or deflection on opening with no symptoms, do you recommend any further testing like a CBCT, or do you just note it and proceed with ortho?
That's okay. I have a whole section here on disc displacements according to a Wilks classification. A deviation with a click, I think, is something that's, especially if the patient's a bruxer, might want to put that patient in a splint to see if you can get rid of the click. That's a patient that there's something called a Wilks 2 patient where they begin to have clicking and popping with occasional locking. So if a patient's deviating, that already is kind of a locking where that disc is not really moving normally with the joint. And the later in the opening, the longer the patient deviates before they correct back to midline, that's something I'm concerned about. I'm not ready to go jump in there with that patient. I might want to put them in a splint just to see how they do. In those patients, what you can also do, real simple thing, is if that patient typically may have a very deep overbite, some constricted envelope of function, have the patient come forward, edge to edge on their front teeth, have them open and close in a protrusive position. And if that eliminates the deviation, you know, it's probably gonna work out well with the ortho, but I think you should be able to handle a flat plane splint on that patient, especially if they're bruxing, you know, short term, just to rule out that could be a patient that you put in braces and all of a sudden they're going to lock on you, and then you've got an issue.
And if I can just add to what you just said, just from a show of hands, how many people here routinely make splints in their practices for occlusal, for issues that we just discussed of any kind? Raise your hand if you're doing splints on a reasonably, you know, decent basis. And I don't see a lot of hands going up. And what I wanted to tell everybody, just because of, again, I used to make splints a dime a dozen as a GP, and it's carried over into my ortho. Would you agree with me, Hal, that when you do these splints, that it often, it makes them understand even more so why they need ortho? Because when they wake up in the morning and they're in fully rested position, and all of a sudden it takes them 10 minutes to adjust into their bite, all of a sudden they're begging you to do ortho because they finally get what's the difference between the two different bites. And even more so, it can often show disguised surgical need, because when they're in CR, they fall back 2 millimeters. Suddenly they're no longer an end-on class 2 adult, they're a full class 2 adult. And now you may be talking surgery rather than just ortho.
Correct. The other thing that you'll see, and because I do see a lot of kids, is I'll see a 9 or 10-year-old and they've got an obvious TMJ problem, their joints hurt. And I'll ask the kid or their parent, I go, are they having any headaches? And the kid always goes, no, I don't have any headaches, you know, 9 or 10-year-old. Well, we treat them, we put them in a splint. Then the first thing I get the next time I see the patient is, Mommy, my headaches went away. In other words, kids don't know what a headache is. They've been living in it their whole life. And now when you take away the pressure on the joint, if it was a TMJ related headache, all of a sudden their headache went away. They didn't even know they had a headache. So yeah, I mean, it does teach, splints teach you a lot about the patient's occlusion and teach the patient a lot about what's going on in their mouth. They're very, very instructive.
Well,
everybody.
It's amazing tonight, and I know we could go on all night with questions, but at some point, it's funny. Great one, Leon. Leon said, now I think I need a splint. I think we could certainly pick your brain in the future if you'll allow us. I'd love to talk to you and the group to find out about maybe getting us to you or you to us. Or
how many are you total?
Right now, about 70, 72.
Oh. Well, I had to. When I'm going to be speaking in Dallas on the 20th. How many people are going to be there?
Of June?
No, October. I'm speaking to your group.
It's always helpful to know the month.
Right, October 20th. Yes, it is. You're right.
Yeah. So I can speak to the group and find out, you know, who can do what. But either way, I think everybody here, the fact that we started with, you know, 17 or 18 people, and then right now we have 17 people, tells us that everybody was really intrigued by what you were talking about. And so all of this has been recorded. I'm going to upload it to the YouTube channel tomorrow. I will create the CE question because I give CE, not you, so you don't have to worry about that. But I would love to get your feedback on tonight when you guys have a chance. And of course, I want to thank you, Dr. Menchel, for giving of your time. You're one of the most generous teachers I've ever met, and I'm genuinely grateful for having you in our lives.
Well, thank you, Glenn. And I'd be, you know, if whether you want me to set something up in full, I'll talk to you as to what we do.
Yeah, okay, we'll talk about it.
Obviously, if we're gonna, the place you really learn what's going on is watching in a small clinical situation. I mean, I can lecture to people all day, and if they take 30% of the information home with them, that's a lot. That's just the nature of the thing. But when you really sit down and you're working in a clinical situation, you see what's going on. You know, that's when you really learn what's going on.
Yeah, and I could almost say to you that from just being where I was in my life and now being in ortho, I think a place that would be very helpful is understanding diagnosis and basic treatment of TMD or any sort of joint-related disorders, and then the concept of an occlusal equilibration and how to properly do them, followed by splint therapy. I think if they have those three tools in their pocket, any orthodontist can handle the variety of things that come through their door.
I agree.
So, I'll touch base with you after I talk to the group. And again, before I sign off, there are a ton of people who've written in the chat, thank you. And I know I'm one of them as well. So Thanks again. Have a
Okay.
wonderful evening. And
I'm going to head for my bourbon, so we'll do that. Okay.
okay. And I will. I'll end the meeting, but I'll touch base with you tomorrow.
Okay, sounds good.
All right. Thanks, everybody.
Be
And,
well. Okay.
have a great night.
All right. You too.
All right.
Bye-bye.
Bye-bye.